Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Like today's webinar, the topic is very important. The topic for today's session is left atrial appendage tachycardia, a case-based discussion. And for this important case discussion, we need someone who is expert. And he is none other than Professor Dr. Chandrabhan Meena sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, DM in cardiology, senior professor cardiology at SMS Medical College, Jaipur. And by taking not much time, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you very much, and thanks for giving me this opportunity. Today, I'll be discussing a unique case because we know supraventricular tachycardia is one of the common presentation in patients who have significant history of recurrent palpitations, especially younger patients, more common in females. But atrial tachycardia, as such, is less than 5% in all the patients who have supraventricular tachycardia. And out of these also, the left atrial appendage is very rare to have the origin in the form of atrial tachycardias. So I'll be discussing this unique and important case, which we came across over last 3 months. So how did we go about it, and what is the importance of this? And briefly after the case, I'll be discussing what is the role of electrophysiology study and what is the development and history of electrophysiology in the management of tachycardias. So this is the clinical history, brief history. Patient was a 33-year-old female who was normal before, but she presented to a local hospital with one-day history of palpitation and dizziness, and where the ECG was done, and it was supposed to be a non-narrow QRS tachycardia with heart rate of approximately 230 beats per minute. She was very uncomfortable. Initially, she was managed. There was no clear-cut definite evidence of what was the response to the IV administration, because that is the drug which we give to differentiate whether patient has got pathway mediated tachycardia or other supraventricular tachycardia. And she was transferred to a tertiary care center, and she was started on oral tablet diltiazem 120 milligram. She was controlled for some times, and again she had recurrence of these symptoms. So after 6 months of recurrent palpitations, she was admitted in our hospital for evaluation. She was referred from there, and on examination and evaluation, we found that she had large left atrial appendage, which is usually thought to be a vestigial organ. She had normal ejection fraction on echocardiography, and she had narrow QRS tachycardia. So we made a possibility of atrial tachycardia. But on further evaluation, we found that the source of origin is not from the left atrium, but it is from the left atrial appendage, which is very rare source of application. So her vital parameters were normal, and there were no clinical findings as far as this cardiovascular system and other system examination were normal. And CNS examination was also normal, because there was no history of previous stroke or TIA. Because these patients who have the left atrial appendage tachycardia are prone to have developed thrombi, and they develop stroke and TIAs. So at present, she was clinically normal as far as the CNS examination is concerned. So this is the initial ECG which we got in the lab after the patient was put on the EP study, and which this has shown. This showed that you can see the definite P waves after QRS. So this is suggestive of long RP tachycardia, which I'll be discussing what do we mean by this. So the distance between or the timing between the QRS and the P wave is more than 70 millisecond, and if the P wave is visible on surface ECG during tachycardia, it is always almost long RP tachycardia. That means the timing between the onset of the QRS and the P wave following the QRS is more than 70 milliseconds. So this is a long RP tachycardia, and the differential diagnosis of long RP narrow QRS tachycardia in patients who have supraventricular tachycardia is either atypical AVNRT, or it is a pathway mediated tachycardia or atrial tachycardia. So how to differentiate between these three, we'll be discussing later on. So she had long RP tachycardia. Rate is very fast; it's almost around 230 beats per minute. But we can see there is some variations. So that may be because of the changing the circuit of the tachycardia. This is the normal baseline ECG after in the sinus rhythm. So there is no evidence or no clue of left atrial enlargement. So the P wave is normal. And if you look at the least 2 and the V1, both are there, and the other there is no ventricular chamber enlargement. So baseline ECG was normal. This is the initial evaluation. So we saw the echo that this is the parasternal long axis view, and this is modified view which showed there is a left atrial appendage which is hugely dilated. So this is the left atrium, and it is continuing the left atrial appendage. So this is dilated, and the dimensions are 6.1 into 4.7 centimeters. So it's hugely dilated. So we got the MRI done. This is again shown a significantly enlarged left atrial appendage, which is continuing to the left atrium. And in such cases, there are high chances of the patient may develop thrombus in the atrial appendage, and they can have stroke, and they can have the arrhythmia because there may be some arrhythmic foci once the left atrial appendage gets enlarged. Similarly, we got the CT scan also done, which has also shown the contrast CT that significantly enlarged left atrial appendage, which is continuing to the left atria. So since she was symptomatic and she was not controlled with the drugs, so there was indication for electrophysiology study. So she was got ineffective medical therapy. So EP study was. She was admitted in a hospital, and this is the preparation for the EP study. Normally, which is routinely done in the patient that we take a high risk consent because we need the transseptal puncture. We have to go through the interatrial septum and go to the left side of the heart. So there are some finite chances of having pericardial tamponade and other complications or A embolism. So we take a high risk consent. Patient was prepared for this, and we got two venous sheath puncture on the right side and one arterial puncture on the right side also to put the three sheath 6F and 5F venous sheath 5F pigtail in the femoral artery, so that we have to landmark in the sending out the root aortic root and the coronary sinus. So one of the CF venous sheath was used to put a decapolar catheter, which has 10 holes into the coronary sinus, and the other sheath was used to put a His catheter to do the activation from the atria to His to the ventricles. And on the induction, initial finding was the tachycardia cycle length was 303 milliseconds. And based on the morphology, it was suspected that the tachycardia is arising from the left atrial focus. So we straight away went for the transseptal punctures. For transseptal puncture, we used 8F short sheath with broken bone needle. And once we got the transseptal puncture and the sheath was introduced in the left atrium, we put the electroanatomy, we hooked the patient with the EP system, that is 3D electroanatomic, that is inside precision system by St. Jude. And we used the SD grade mapping system, which has 14 poles as far as the electrodes are concerned, to map the origin of the tachycardia. Other catheters are the decapolar in the CS and quadripolar in the His. So this is the sheath which is after the transseptal puncture in the left atrial appendage. We can see this is the left atrial appendage which is dilated. Sheath is in the left atria. And if you look, this is we have taken the angiogram which has shown the hugely dilated left atrial appendage. This is the central part of the left atria, and this is the left atrial appendage. And if you look at the other view also, we can see that it is hugely dilated, which is connecting to the left atria. So it is hugely dilated left atrial appendage, and sometimes may be difficult to localize the origin of the tachycardia, and may be difficult to ablate the tachycardia if they arise from the left atrial appendage. So this is the intracardiac electrogram during the tachycardia. The upper three panels show the surface ECG. This is the lead 1, lead 2, and lead 3. So if you look at the lead 2 during tachycardia, it is positive, and if you look at the lead V1 in the ECG, it was positive, suggesting that the tachycardia is arising from the left atrium. And these are the coronary sinus catheters showing from CS910 to CS1. So CS12 is the distal catheter in the distal end of the coronary sinus, while the 7-8 is the proximal at the coronary sinus os. So tachycardia, it is almost simultaneous indication. And these are the signals on the ablation catheter, which show the distal ablation catheter. So these are the P waves, and on ECG, these are the P waves. And if you look at the A wave, it's corresponding to this, and these are the QRS. We look at the distance. This is a long RP tachycardia. It is more than 150 milliseconds. So this is the electroanatomic mapper, which has shown the voltage map. So there is no scar. So if you have the scar, you will find the gray area. But if you have the purple, that means so there is no the atrial cardiomyopathy or the scar in the left atria or left atrial appendage. And this is again another view which has shown the propagation map again. So this is the red signals which are shown in the right atrial RAO view and LAO view. So this is the point of origin where you have the earliest origin of the tachycardia. These recordings are done during the tachycardia only. So these are the sites where the tachycardia originates, and then it propagates to the other part of the atria and to the ventricle. So this is the coronary sinus catheter we can see on the 3D mapping system. So these are the 10 poles, and the distal pole is the CS12, and proximal pole, which is the near the coronary sinus source, is the CS9 turn. So based on the propagation of these wave fronts, we can find out where tachycardia is origin from the distal to proximal CS. And this slide showed the activation map. If you look at the activation map, once the tachycardia starts from these focal points and then it propagates to the whole of the atria. So this is very interesting sign that this can show that this is the site of most likely site of origin of tachycardia where we should try to ablate the patient. So these are the two different views. These are the right atrial, right RA view, and these are the LA view. Again, if you look at the propagation map, this is again confirming the same finding. This is the focal point where the tachycardia is originating, and then it is propagating to the rest of the chambers. So this confirmed the diagnosis that patient has origin of the tachycardia at the entrance of the left atrial appendage. So once the other menu is also concerned, which I'll be discussing, that it is a atrial tachycardia and site of origin in the left atrial appendage, we went ahead for the ablation only. And for ablation, we took the Tachycat catheter, that is the force sensing catheter, and these are the activation map finding that the site of origin was 78 milliseconds earlier than the P wave, and the with first ablation only the tachycardia condition. So this is the setup screen which is shown where the ablation catheter was introduced. So this is the location of the ablation catheter where we got the signal. It is 78 milliseconds earlier than the onset of the P wave. And if you look at the parameters of the contact force, which show the timing and the force which is applied with the during the ablation, this force is 8 gram, and this is the FTI, that is force time index. So it is for 3 seconds. If you multiply 8 by 2, it gives the FTI as the 24 grams per second. So if the force is applied of 8 gram for 3 seconds, FTI will be 24 seconds. And this is the initial the part of the recording which showed that patient is in tachycardia. And once we started the ablation, just after the 2 seconds, this is showing the this indicator shows the timing after the onset of the ablation. So within 2 seconds, the tachycardia terminated and patient got this back into cynicism. So this is the tachycardia, and this is the normal PRS, PQRS, and so onset of the normal sinus rhythm only. So within 2 seconds, the tachycardia got terminated. So we continued the ablation for the 60 seconds. And after that, we did the other maneuvers to induce the tachycardia again. The tachycardia were not inducible, and it was successfully terminated. Even after the pharmacology, like giving the isoprene, the tachycardia was not inducible. So we had successful ablation of the tachycardia. This case is interesting because this is one of the rare cases where you get the tachycardia originating from the left atrial appendage. And with such a huge left atrial appendage, only 7-8 cases have been reported in the literature. Normally, the tachycardia may arise from the left atrial appendage, but the size of the appendage is normal. So either it may be because of the tachycardia that left atrial appendage has got enlarged, or primarily there may be abnormality, the anatomical abnormality of the left atrial appendage that has given rise to tachycardia, which will be very difficult to confirm. But this is interesting case and very difficult because she was very symptomatic and she was not controlled on the drugs. So post-procedure follow-up, the echocardiogram was normal, so there was no pedicle effusion, there was no neurological deficit, so there was no stroke or emboli during the procedure or after the procedure also. She was discharged after 10 days, and she is asymptomatic now for 2 months. But earlier she was having recurrent palpitation. So this looks like that she had successful ablation of the tachycardia. So now I'll briefly discuss about the history of electrophysiology for the benefit of the audiences. The first his bundle recording in the human heart was done in almost 1893 by Dr. William Hayes, and after that, first human ECG was recorded by August Waller in 1887, and we know Enthoman developed the currently used ECG recording, and Purkinje fiber, AV node, and other similarly these recordings were done later on up to the 1839 to 1907. And early ablation with the use of DC current was done in 1990s. And after that, the RF ablation has become the standard of choice as far as the management of supraventricular tachycardia and some cases of ventricular tachycardia is concerned. So this is Dr. Melvin Shyman, who did first ablation with the use of direct current in patient with supraventricular tachycardia. And this is the patient who had shown they had treated the patient with supraventricular tachycardia with DC current. But after that, the patient developed AV block and patient has to be given pacemakers. This is the rate after 37 beats per minute after the tachycardia. So patient developed AV decision, but there was successful treatment of supraventricular tachycardia. Later on, there have been very many refinement in the management of the supraventricular tachycardia and the energy sources, and the catheter ablation has become class 1 indication for most of the supraventricular tachycardia. Finally, Hesseger and his group in 1988 found that patients have focal origin of tachycardia, especially the left atrium, and these are the sources of patients who develop atrial fibrillation. This is one of the important findings. The patient have focal pulmonary vein, that's the left upper pulmonary vein, is the most common source of these focal tachycardias. And if you isolate or the pulmonary vein isolate ablation, then patient may have successful treatment of the atrial fibrillation in these cases. These are the some evaluation how the management of pulmonary atrial fibrillation, we use of empirical pulmonary valve isolation or wide area circumferential ablation. So these are different strategies which are used. It is not related to our case, but it is one of the important ablation strategy in patients with atrial fibrillation. And these are the catheters which are used to map and ablate these patients. So some of the basic fundamentals or core concept of the electrophysiology. So the main purpose of the EP study is to evaluate the cardiac arrhythmia along with non-invasive diagnostic testing. And these are used in patients who have sinus node dysfunction, AV conduction abnormalities, SVTs, patients with ventricular tachycardia, especially with normal heart, on patients who have post-mitral infarction, VT also. Those who have on AICD and getting recurrent shock, we can do catheter ablation in these patients. And the post-ablation assessment is to confirm the success and to rule out residual arrhythmogenic focus. These are some of the contraindications like patient who have high bleeding rates, acute coronary syndrome, or patient affecting the arrhythmia diagnosis and pregnancy is one of the contraindications. So this is how the mapping catheter records the wave electrogram when it is coming. So if the wave is propagating towards the electrode, it is recorded as the positive wave, and if it is going away from the recording catheter, it is recorded as the negative wave. And if you have the two poles, it is a biphasic wave. Otherwise, if you have the unipolar catheter, you will have the unipolar recording. So these are the different recording. So this is the normal basic EP study findings. How do we get the findings? We have setting upper the three surface ECGs. Then we have his recording. Finally, we have coronary sinus and then right ventricular. So we map entire the conduction system of the heart, starting from the SA node to the ventricles. And these are the different timing intervals or the intervals like what is the AH interval. So intracardiac recording from the A wave, that is the sinus route, to the his bundle, and from his bundle to ventricle, which denotes the conduction time from the his Purkinje system. That is known as the HU interval. So I'll be discussing what it is. So this slide shows that these are the different catheters. Normally we have four catheters. One is the coronary sinus, other is the right ventricle, one is the his, and one is the high right atrium. So these are the basic EP system or EP setting in most of the patients we have in the EP study to diagnose and to manage the arrhythmia in this patient. And this is again same showing how do we put the ECG and the intracardiac electrogram in order. So initially we have the three surface ECG followed by the right atrial and his and CS, and lastly we have the RV recording electrograms showing on the display screen. So some of the terms as far as the EP concepts are concerned. So timing cycle or the cycle length is the duration between the any two events like either the P waves or the A waves on the intercardiograms or QRS on the ECG or the RR interval in the electrogram. Normal is 600 to that is 600 milliseconds, that is 100 beats per minute. Programmed stimulation is when we have controlled pacing via the catheter. So we have catheters inside the heart and we can pace from any of the catheters. But at the program duration and cycle length, along with the strength of the current and the duration of the impulse. The burst or incremental pacing is when we have progressively shorter cycle length, and extra stimulus pacing is when we have the regular pacing cycle length up to 8 to 12 beats, and then we give a premature beat, so that is known as extra stimulus. We can have one or two or up to three extra stimulus also, that is known as double or triple extra stimuli. Coupling interval is the timing between the normal beat and premature impulsion, and the effective reflective period is the longest coupling interval where no impulse is conducted, even if you increase the strength of the conduction. And these are some of the intracardiac parameters. The PA interval is the duration between the onset of the P wave to the lower atrial signals in the his recording. So if you have the catheter in the RA and you have catheter in the his, so what the duration between the onset of the P wave to the A wave in the his catheter. Normal duration is 25 to 55 milliseconds. AH interval is from the atrial signal to the his bundle recording in the his catheter, and the normal is the 55 to 120 milliseconds. The H time is the conduction through the his bundle, and that is less than 30 milliseconds. And HV interval is from the onset of the his to the onset of the QRS. That is again 35 to 55 milliseconds. That is the normal heart. But if it is prolonged, then it is the abnormal. And in some of the patients, like in patients with complete heart block or conductional system, the timings may be changed. So as far as the technique is concerned, it is the signal interpretation. So we have to have the faster speed so that we can see all the signals separately. Like in normal ECG, if we have the paper speed up to 25 millimeter per second, you may not be able to see the different waveforms. So in EP study, we keep the sweep speed of around 100 to 200 milliseconds per minute, so then we can see different signals set properly. Electrograms are the atrial and ventricular signals which are easily identified. His bundle recording again can be identified, and as I discussed, we need at least coronary sinus catheter and two quadripolar catheters, one in the his location and other in this RA, and we have one ablation catheter. So we at least in basic study we have four catheters. So this is what initially I discussed, how to differentiate whether the patient has the AVRT, that is the pathway mediated tachycardia, or AVNRT, that is AV node reactant tachycardia, or if the patient has atrial tachycardia, which are the most common three types of supraventricular tachycardia. So if we pace from the right ventricle, so this is the catheter which is in the right ventricle, and if we see we start after this pacing, we stop pacing, and what is the response after this once the pacing is stopped. So if we have VAV response or VAHV response after the stopping, it suggests that patient has either AVRT or AVNRT. But if we have VAAV response, that means if the at this cartoon showed that the focus of origin of the tachycardia is in the atria, and if we pace from the ventricle, it will capture it, so that it will have once we stop the pacing, the tachycardia will start from the A only. So the next beat will be starting from the A. So in the intracardiac recordings, we have VAAV response. This is a diagnostic of atrial tachycardia. So this is what we got in our patient also. That's how we made the diagnosis that patient has atrial tachycardia. And finally, we located that the origin is in the left atrial appendage, and we ablated. This is the one again timing cycles. So that's based on the post pacing interval. So if it is more than 150 milliseconds, it is suggestive of AV node reactant tachycardia, and if it is less than 150 milliseconds, it is diagnostic of pathway mediated or orthotomic reactant tachycardia. This is the slide which shows intracardiac recordings after the pacing. Again, we start the normal sinus interval. So we have the pacing, and once we stop the pacing, we see what is the response. It starts with the A or it starts with the V, and what is the post pacing interval. So this is how we calculate, and we come to the conclusion to what the diagnosis. And this is the slide which shows that it is almost 100% specific for the diagnosis of AVNRT or ORT and atrial tachycardia. So if we have VAAV response, it is almost certain that patient has got atrial tachycardia if the response is true. And what is the successful finding? The main after post ablation, main success indicator induced non-inducibility of the pathway of the tachycardia which was previously ablated, and even after the use of drugs like isoprenin, or in some cases other pharmacologic drugs also. So if tachycardia is non-reducible, we label it that patient has got successful ablation of the tachycardia. Thank you very much, and we are open to the discussion if there are any comments or comments.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions. With all your permission, shall we take these questions one by one?
Yeah. So can I exit the screen so that I can see the
Yeah,
I can
yeah,
see.
you can, sir. You can, no problem.
Okay.
Yeah, you can open the
Yeah. Yeah.
browser.
Okay.
Yeah. So the first question we will take from the participant is that what are the key ECG features that help differentiate left atrial appendage tachycardia from other form of atrial tachycardia or atrial flutters?
Atrial flutter is totally different tachycardia. So if you look at the atrial flutter, the most of the common side is the right atrial flutter. It is have either the clockwise or counterclockwise. So there is a definite circuit in the right atrium. In those cases, we'll see sawtooth appearance. That is, you have uh, the either first the atrial wave or if you look at the P wave, the rate will be around 250 or 300, and it will be negative in the inferior leads. So in the lead 2 and 3 and AVF, we see that P waves will be negative, while if you have the clockwise, it will be positive. And in atrial tachycardia, we will not have such findings, especially if you the left atrial tachycardia, if you, the lead V1 is more important. In this case, if since the tachycardia is arising from the left side, the lead V1, the P wave will be positive. While if it is arising from the left atrial appendage, because the atrial appendage, left atrial appendage is the highest, this most superior structure, so the inferior leads will be positive. So the P waves will be positive in lead V1, and similarly the P waves will be positive in lead 2, 3, and AVF. That may give some clue that patient has tachycardia arising from the upper part of the left atrium. It may not be from the. So just based on the ECG, it will be difficult to localize that it is arising from the left atrial appendage, but it can be made that patient the tachycardia arising from the left atrium or right atrium.
Thank you so much, sir, for sharing your expertise on that question. We will be taking another question, sir. Sir, in hemodynamically stable patient with subjected left atrial appendage tachycardia, what should be your preferred diagnosis and mapping strategy?
So that's why I say if you have 3D mapping, 3D anatomical electroanatomical mapping, that is the most important, which we use in these cases. Because for the conventional 2D EP mapping, it sometimes may be difficult or it may be rather time consuming. It may not be difficult in expert hand, but it will be time consuming. But if you use a 3D mapping system with the multi-array system like SD grid, it will be very easy, and it will be less time consuming. So you can within say 5 to 10 minutes you can map whole of the left atrium, right atrium, and the atrial appendage also. And the catheter is very soft, so there is no chances or there is no risk of perforation in this way, because especially the appendage is very the delicate structure. So using 3D anatomical mapping, and if you have ultrasound, especially the intracardiac echo, which is nowadays used most more commonly, it will be very easy and less time consuming to map the tachycardia of left atrial appendage.
Thank you so much, sir, for sharing your expertise. One feedback from Dr. Subramaniam. Very good case-based discussion. Thanks for this presentation.
Thank you. Welcome.
Welcome, sir. And sir, I can't see any further questions, sir. I hope you have done justice to this topic. As there is no
Okay.
more further questions, with all your permission, shall we conclude this session for today?
Yeah, thank you, and I hope it was
Yes,
helpful, and
sir.
it was beneficial, because this was unusual case. So I thought, rather than having some theoretical discussion, we should discuss the case and have some discussion about this only. Thank you very much.
Yes. Welcome, sir. And we would like to see you in future also with different topics, sir. It was great
Thank
honor to have you on our platform. Take care, sir. Thank you
you.
so
Okay.
much for joining.
Thank you. Bye bye.
Bye, sir.